Good evening, all. My name is Alfy Olufade, and welcome again to AMSSM's National Fellow Online Lecture Series. As a reminder, this is sponsored by the Fellows Online Educational Subcommittee, the Education Committee, as well as the Fellowship Committee. It's with great pleasure that I welcome a friend of mine and a colleague, Dr. Augustine Conduah, to be talking today about common traumatic injuries of the lower extremity. Just as a reminder, next week, we're going to be having another talk. It's going to be on medical legal aspects of sports medicine. This is going to be moderated by Milo Liu, and Chad Absent will be the presenter and the speaker next week, Wednesday. As a reminder, the goals of these lectures is to act as an adjunct to the on-program education, also to kind of provide fellows with direct access to educational experience with AMSSM members, as well as sometimes invited guests like we have today in Dr. Conduah. Finally, the goal is to assist in CAQ examination preparations. Just some housekeeping rules before we get started. Please remember to mute your device and turn off your screen. Remember to submit questions through the chat line, chat function. Myself as the moderator will help with the Q&A session after Dr. Conduah is done speaking and presenting today. At the end of the day of the talk, there's going to be an evaluation to be completed. Please feel free to kind of fill that out and tell us how we could do better. Also, we need your input on different types of topics and other things that we could do. Topics, speaker suggestion, please go to the AMSSM.org. Click on the education section, as well as the fellow online lecture series. There's a QR code to follow. Feel free to kind of take a look at this and give us some recommendation and advice on some of the things that you think we could do differently or do better at. Before we get started, I would like to give a quick introduction to Dr. Augustine Conduah. He's an assistant professor at Emory University School of Medicine, specializing in sports injuries and arthroscopic surgery of the shoulder and knee. Having completed an AO North America Fracture Management preceptorship, he has clinical interest in orthopedic trauma. In addition to his clinical interest, Dr. Conduah is a co-director of the Emory Summer Scholars Program, a summer immersion program that aims to expose and recruit women and underrepresented minorities to exciting field of orthopedics. Dr. Conduah completed a sports medicine fellowship at Houston Clinic. Prior to becoming a Houston Fellow, Dr. Conduah completed his orthopedic surgery residency training and a one-year basic science research fellowship at the David Geffen School of Medicine at UCLA. He also earned his medical degree from David Geffen School of Medicine at UCLA, where he was named Leonard Marmor Arthritis Foundation Scholar, and he received the letter of distinction in surgery. He graduated from Stanford University with honors, majoring in human biology, and has consistently been named among Castle Connolly and Atlanta's Magazine top doctor each year since 2016. Dr. Conduah serves as a team physician of several local high schools, as well as the team physician for WNBA Atlanta Dream. Dr. Conduah, thank you very much for presenting today. I appreciate it.
Awesome. Thanks so much for the introduction, Alfie. I really appreciate it. It's my pleasure to be here. Hopefully we can get some good takeaway points and learn something tonight. Perfect. Okay, so let's talk about trauma in sports. So no disclosures tonight in reference to this talk. So when I consider or think about trauma, I think about gunshot wounds, auto versus pedestrian, even motor vehicle accidents. But what do we consider trauma in sports itself? You certainly have to remember that trauma can oftentimes be a catastrophic event to players and may even be life or limb threatening. So the objectives of this talk tonight is really discuss, the initial management of various musculoskeletal trauma, as well as identify and appropriately triage patients in the setting of traumatic sports injuries, and of course, review some specific traumatic sports injuries as well as their treatments. So catastrophic injuries can certainly occur while participating in sports. They can be either indirect, due to systemic failures such as, compartment syndrome or even rhabdomyolysis, or direct from trauma such as collisions. We tend to base these or separate them into three categories, being serious, non-fatal, and unfortunately fatal. So the incidence of catastrophic injuries, as one would expect, increases with the level of competitiveness, seeing a fourfold increase in catastrophic injuries in collegiate athletes versus high school athletes. And as one would expect, football has the highest incidence of direct trauma-related injuries when compared to all sports. In addition to football, we see traumatic injuries in pole vaulting, gymnastics, ice hockey, female sports in particular, cheerleading and gymnastics. I consider gymnastics a collision sport where the participant is colliding with the ground or other instruments. As far as traumatic injuries in sports location-wise, we tend to see them in the head and spine, of course, the upper and lower extremity, and to a lesser extent, the pelvis. So triage is of utmost importance. We certainly need to make the distinction between injuries that are treated on the field and either need to go to the emergency department with operating room urgently versus treatment that can occur on the sideline with possible referral either to a specialist post-game or actually even return to play. Emergent injuries tend to be, long bone fractures, open fractures, open joint injuries, of course, head or spine injuries, and major joint dislocations such as the knee itself. Now, specifically, injuries that may require removal from play include significant ligament injuries of the knee, many reducible dislocations such as shoulder dislocations, and a lot of hand or foot fractures, as well as musculotendinous injuries, which tend to be hamstring injuries for the most part. Now let's talk about the initial management of trauma. So of course, the ABCs are exceedingly important. The initial evaluation of the athlete begins with whether or not the player, him or herself, is actually responsive. If they are responsive, of course, we can go on to focus on the actual area of the injury. But if the athlete themselves is not responsive, we've got to go to our basics as far as basic life support and focus on the ABCs, the airway, breathing, circulation, etc. And of course, try the best that we can to determine the Glasgow Coma scale, knowing that a lower score has a higher chance of further injury, higher severity of injury, and even a greater chance of death. So on the field evaluation, potentially injured structures can include the musculotendinous structures, bone, skin, and neurovascular structures themselves. And it's really important to identify injuries that can compromise the hemodynamic stability of the athlete, him or herself. So when on the field, I've been on the field covering various sports for over 15 years. And one thing that I've learned is that one must, trust your instincts, trust your physical examination skills, which not only involves touching, feeling, looking at the athlete or the patient, but also in the initial inspection. We don't have immediate access to radiographs on the football field, for example. So the physical exam is of paramount importance. So upon initial inspection, we look for any obvious deformity, whether or not there's swelling, skin tenting, which could mean near compromise of the skin from a fracture that may be an impending open fracture. We tend to see this in clavicle fractures more often than not. Look for bleeding, exposed bone, and then skin color. It's important to note that skin color changes depending on hemodynamic flow, and that's also dependent on the ethnic background of the athlete. In African-American individuals, skin changes can manifest as a sort of yellowish brown when there's loss of blood flow to the area versus even towards grayish. Versus, Caucasian athletes, which may appear more bluish when they have some skin color changes such as pallor. So that's an important distinction to keep in mind. The initial physical exam, as far as fractures themselves, you want to palpate the entire limb, the entire bone, and look for any crepitus or motion at the injury site. Evaluate for lacerations, which could be a clue to an actual open fracture. And of course, evaluate the joint for stability, stiffness, loss of motion. Neurologic exam is also certainly important, as well as the presence and quality of pulses. As far as management of closed fractures, the main goal is to not attempt to try to prevent a closed fracture from becoming an open fracture. So depending on the nature of the deformity of the fracture itself, the team physician, him or herself, may attempt immediate closed reduction if the fracture is significantly displaced. And it's important when we talk about fracture reduction to assess the neurovascular exam prior to the reduction, as well as assessing the neurovascular exam post-reduction, because there may be a difference. It may be improved, or heaven forbid, it may even be worse. So it's very important to assess the neurovascular exam post-reduction as well as prior to the reduction. And of course, stabilize the fracture with any appropriate splinting material that's on hand. Now, open fractures, especially for orthopedic surgeons that cover the sideline, there's this certain temptation to want to reduce the fracture. When it comes to open fractures, one must really resist that temptation. Cover the fracture site with the soap gauze. Do not reduce the fracture. Do not probe the wound. Of course, do not replace any bone or soft tissue into the wound. Sometimes with comminuted fractures, you can actually have bone that's exposed, that's out of the fracture site and maybe in the grass or turf, and you certainly don't want to return that bone to the area, causing further contamination. So the key is to minimize contamination and try to keep the wound as clean as possible. And of course, getting the patient to the emergency department as soon as possible for both treatment of the fracture itself. When it comes specifically to open fractures, early antibiotic treatment is paramount. Now, as far as dislocations, many of them can be reduced on the field. Simple dislocations such as finger dislocations and shoulder dislocations. One relative exception is the hip dislocation itself. It's not always easy to identify or even diagnose a hip dislocation. Most of those need to be reduced in a more controlled setting where the patient or athlete can be sedated to allow for a more easy reduction. And as mentioned before, document the neurovascular status both before and after the reduction. If possible, try to get to the dislocation as soon as possible before muscle spasm sets in, before significant pain may set in, where the athlete may be guarding, making reduction that much more difficult. And the general rule for reductions is essentially to reproduce the mechanism of injury. You're almost worsening the injury or the fracture, and then applying longitudinal traction. And typically, the athlete's response is they actually feel better, which makes a lot of sense once you reduce the dislocation. And of course, splint and check the neurovascular status. If available, you want to get post-reduction radiographs to verify the reduction, to rule out any associated fractures as well. Peripheral vascular nerve injuries can also occur, and an index of suspicion should be heightened with certain dislocations, especially about the knee and the elbow, with certain fractures such as supracondylar humerus fractures, and with certain crush injuries. Peripheral vascular nerve injuries, as far as the physical exam and things to look for, obviously, swelling, any obvious external bleeding, absent or reduced pulses, coolness of the extremity, hyposthesia or decreased sensation, or even partial or complete paralysis. And of course, if suspected, these sorts of injuries require urgent transfer to the hospital for further evaluation, management, and treatment. Resist the temptation to apply clamps, rather direct pressure to control bleeding. Let's shift gears a little bit to compartment syndrome, specifically acute compartment syndrome. Typically involves the forearm or the lower leg. Inciting factors can be direct trauma, which can cause swelling, muscle ruptures, which can cause swelling, fractures, or even constrictive bandages or casts. I've seen instances of patients who've had their fractures reduced and actually placing a cast as opposed to a split, which is non-circumferential. The cast does not allow for swelling to occur or to dissipate, and that can actually lead to, a compartment syndrome. Now, the clinical exam is key when it comes to diagnosing acute compartment syndrome. The most reliable signs are essentially pain, pain out of proportion to the exam, pain despite offering or giving the athlete or patient pain medication, pain with passive stretch, and the overall sensation of tightness at the extremity, whether it be the lower leg or the forearm itself. So if it is suspected, you want to do your best to elevate the extremity. This may help to a certain degree with some of the swelling, and of course, emergently transfer the patient to the hospital. As far as diagnosing compartment syndrome, in addition to the clinical findings, there's direct objective evidence where you can use a pressure compartment monitoring system where you zero it out, you apply a little bit of fluid, and you get a reading. And typically, it's the rule of 30-30. So 30 millimeters of mercury ultimate pressure, or 30 millimeters of mercury within the diastolic pressure is indicative of compartment syndrome, and therefore will lead to the treatment with fasciotomies. And my model with fasciotomies is go big or go home. You really want to, it's a limb preserving, limb salvage procedure. So you really want to do the best you can to decompress the pressures to allow for further revascularization of the extremity. And this is as opposed to treatment of exertional compartment syndrome, where we can get away with those smaller, sexy incisions and allow for fasciotomy subcutaneously while still allowing decompression of the region and allowing for symptomatic relief with smaller incisions. Acute traumatic amputations can be significant in terms of digits. Cleaning and infection control are paramount. You certainly want to irrigate the proximal step. As far as the amputated digit itself, you want to place it over ice to keep it cool, but not necessarily frozen. Irrigate it, of course, and place it in a bag. The typical timeline is at or about 4 to 6 hours is when you really want to consider replanting the digit. But there has been evidence suggesting that upwards of 24 hours replant of a digit is still feasible. Now let's talk about specific traumatic injuries. Tibia fractures tend to be among the most common traumatic long bone fractures that we see in sports. Upwards of 10% of high school students, as far as fractures, consist of tibia fractures. In a large review, upwards of 6,000 athletes, tibia fractures were up there as far as their incidence, and even higher when we consider stress fractures of the tibia, as well as the foot and the ankle. Now, the initial management of tibia fractures include, as with other fractures, provisional stabilization, look for other injuries, of course, of the head and neck, cover any wounds to prevent contamination, and do not be afraid to take the shoe off, take the sock off, and do a good neurovascular exam. You don't want to find yourself, feeling through padding or spat or tape to try to assess the pulse. And don't guess and don't assume as far as neurovascular status. If you're unsure as far as your documentation, specifically state unable to document or assess neurovascular status secondary to swelling, maybe secondary to the athlete unable to cooperate with the exam. So it's really important to give an accurate assessment of what you see and not try to assume. Now, factors that can affect the outcome when it comes to tibia fractures are any associated soft tissue injury, which could lead to compartment syndrome. And for open fractures, the timing of antibiotics, as well as the transfer to a definitive trauma center, are really the two most important factors when we talk about open tibia fractures, minimizing the risk of infection and improving outcomes. So tibia fractures can be treated, the closed fractures can be treated with casting, and the other option is actually surgery. So closed reduction and casting. Now the tibia itself cannot accept a significant amount of deformity, meaning very minimal varus or valgus can be accepted, less than 10 degrees of recurvatum or procurvatum, and less than a centimeter or so by shortening, and less than 10 degrees of rotation. Anything significantly above that is going to cause a poor outcome and lead to gait dysfunction, alignment issues, which can cause chronic pain and accelerate arthritis around the joint. So for these closed treatment of these tibia fractures, you initially start with a long leg cast and then convert to a patella tendon bearing shorter leg cast to allow for weight bearing. And weight bearing and stable fracture patterns can increase the healing potential as it stimulates the bone to lay down osteoblasts. Average time typically for many tibia fractures are 4 to 5 months, with non-union rates around 10% or less. And that's because of the relatively lower soft tissue envelope surrounding the leg and the tibia versus the thigh. Intramedullary nailing is essentially the workhorse for orthopedic surgeons as far as treating unstable are displaced in comminuted tibia fractures. It allows for earlier weight bearing, as the intramedullary nail itself is a load sharing device. However, it's not without complications. As it relates to the actual entry point, we typically will make an incision that's parapatellar or transpatellar, which can lead to the dreaded anterior knee pain, whether it be with activity or whether it be with kneeling. Similar findings that we see with BTB autografts. So I actually use a different approach when I fix tibia fractures. I actually do a suprapatellar approach. So I make an incision just above the patella itself, make an incision to the quadriceps tendon, and go under the patella to get my starting point. And that obviates the need for a direct anterior incision, and therefore completely eliminates any issue with kneeling or anterior knee pain. Femur fractures are a different animal. They typically require higher energy, and it's much more difficult to actually reduce or splint a femur fracture versus a tibia fracture. But the mainstay of treatment early is to apply longitudinal traction to get some sort of reduction in the fracture itself. And with this being a long bone fracture in a large bone in a vascular area, there's significant blood loss that can occur, upwards of 1 liter to 1.5 liters. So these fractures can and do require close hemodynamic monitoring. Despite the fact that you can lose upwards of 1 liter of blood into the thigh compartment syndrome is much more rare when compared to leg compartment syndrome because of the capacity of the thigh. So again, treatment for femur fractures is essentially surgical in adults with any shortening or displacement. And the nails can be placed antegrade versus retrograde. So antegrade is beginning from the knee upward towards the hip as far as placement of the nail. And that's for fractures that tend to be at the mid shaft or more distal in the femur, versus retrograde, which are placed from the hip down towards the knee itself. And that's for fractures that are more mid shaft or more proximal. So again, with intramedullary nail treatment of these fractures, because the nail itself is a load sharing device, as long as the fracture pattern is stable, i.e. a transverse fracture that can allow for early weight bearing, which can stimulate healing. Complications that can be associated, especially with the antegrade nailing, because of the entry point, especially if it's near the piriformis site on the proximal femur, can cause hip abductor weakness and even pain at the hip. As an adult, pediatric femur fractures can be treated with intramedullary nails, but these nails are more of a flexible type, and they can be placed with percutaneous incisions in the bone, and you can place 2 crossing flexible nails. Now, what about return to play after femur fractures? In a study in 2015 that reviewed treatment of 4 professional athletes with isolated femur fractures, they were all treated with intramedullary nails, and they essentially all healed and returned to play at 9 or 10 months. And in this article, the authors stressed the importance of rehab, specifically that of hip abductor training, hip abductor strength, early range of motion, as well as quad strengthening. Knee dislocations, the dreaded injury. In my opinion, joint injuries, as far as traumatic joint injuries, including dislocations, can be more significant than actual long bone fractures. If you think about it, the long bone fractures are not intimately related with the joint itself. So most of the issues that patients have to sort of overcome surround the ability of the bone itself to heal versus joint injuries. You're talking about getting stiffness, you're talking about allowing for stability, and of course, surgical management. So they can be more catastrophic, if you will. Knee dislocations outside of trauma are typically as a result of a rotational force. There are typically multi-ligaments involved, upwards of 3 to 4. And the issue with knee dislocations is that there's a high association with knee dislocations and vascular injuries, especially the anterior and posterior knee dislocations. And that's specifically due to the popliteal artery, which is intimately related to the posterior tibia proximally. Furthermore, perineal nerve injuries can occur at about 25%, and that's manifested by a foot drop. And there are some associated fractures that we see, such as proximal fibular fractures with knee dislocations. As far as classification of knee dislocations with other dislocations we discussed, the classification based on the distal part of the extremity. So if we're talking about the knee joint, it's where does the tibia go? And that defines the nature of the dislocation. It's a tibia posterior, that's a posterior dislocation, anterior dislocation, etc. Most commonly with knee dislocation, we see anterior ones, but the ones that can be pretty scary are the posterior ones because they have a high incidence of associated popliteal vessel injury or compromise. So as you would guess, knee dislocations require emergent reduction. And again, you'll see this common theme here. Evaluate for pulses, check the neurovascular exam before and after reduction. Specifically in the setting of knee dislocations, one must check for distal pulses after the reduction. If their pulses are absent, that's really sort of sets the clock ticking as far as the time of ischemia and the higher incidence of amputation, which can be upwards of 85% if ischemia time is more than 8 hours. And there is such thing as having a vascular injury in the setting of palpable pulses. So don't always be fooled by that. Prognosis of knee dislocation, again, is based on the presence of complications, i.e., perineal nerve injury, neurovascular injury, and return to pre-injury state is relatively rare, with less than 50% of athletes actually being able to return and less than 20% or so to be able to return to pre-injury level of play. Because of the joint, as we discussed, the risk of joint injury, there's an increased risk of stiffness. So the earlier these injuries are managed and repaired, once the motion is achieved, the better that the athlete or patient can do. Hip dislocations, relatively rare. You can see some more famous examples with Tua and the OG, Bo Jackson. His hip dislocation is what led to his avascular necrosis, which is what led him to receive a hip replacement. And amazingly, he went on to play baseball, but wore out his hip in less than 2 years. Now, as far as the mechanism, is due to a fall with a combined knee and hip flexion moment. Posterior hip dislocations are the vast majority of the hip dislocations, and the position is hip flexion, adduction, with internal rotation is how you'll see the limb. And as mentioned before, reduction of the hip often requires, adequate sedation and of course, imaging pre and post reduction. Timing is critical. The issue with hip dislocation is that you actually cause or can have an injury to the medial femoral circumflex artery, which is related to the blood flow of the femoral head. And injury to such can lead to osteonecrosis and upwards of a third of hip dislocations. The timing is critical. You want to reduce these within 6 hours. And it's important as far as post-reduction studies to get a CT scan so you can first, of course, verify reduction, which is often palpable at the time of the reduction, as well as rule out any bony fragments in the joint itself. Now, there is a specific technique, I call it the Captain Morgan technique, where you flex the hip to 90 degrees, you bend the knee or the injured leg over your knee, and you hold an internal rotation and you apply direct anterior traction. There's a very gratifying clunk that you feel unlike any other clunk as opposed to reducing shoulders. But of course, hip dislocation are not without complications, as mentioned, avascular necrosis, sciatic nerve injury, heterotopic ossification, which is bone that forms where it should not, which is typically the result of a trauma, an injury, or even surgery. There's also a risk of DVT with hip dislocations as well. Recovery, the athlete is placed on hip precautions. What are hip precautions? They're basically specific guidance to a patient in terms of what position their hip should not be placed on to increase the risk of further or subsequent dislocation. So in the case of posterior dislocations, the hip itself wants to dislocate when it's flexed, internally rotated, and adduction. So hip precautions teach the patient how to get up and stand and even grab things from the floor without getting in that position to minimize the risk of further dislocation. Let's shift gears a little bit and talk about sternoclavicular joint dislocations. The ones that tend to be most crucial, if you will, are the posterior sternoclavicular joint. because of all the vital structures posterior to the sternum itself. This is seen, of course, in higher contact sports such as rugby, martial arts, and even motocross on occasion. And the complication with these posterior dislocations can be quite grave, and there's complications upwards of 25% of the time. You've got the great vessels back there, you've got the larynx, you've got the trachea, so patients can present with difficulty breathing, difficulty swallowing, or even blood that fills in the chest itself. The gold standard for imaging studies as far as diagnosing sternoclavicular joint injuries is CT scan. So these athletes will typically present with pain and difficulty moving the extremity of the involved side. Sometimes there's actually a palpable defect. And again, as I mentioned, the athlete may report difficulty breathing or even swallowing. Beware of swelling. There can be swelling at the area that can actually fool you into thinking the sternoclavicular joint dislocation is anterior as opposed to it being a posterior dislocation. The reduction technique for acute posterior dislocations is essentially using a towel clip to grab that medial head of the clavicle, pulling it forward. Because we're dealing with vital structures in the area, it's important that this be done in the operating room setting with the thoracic surgeon present in the event of. Now, again, as mentioned, treatment depends on how acute or symptomatic the patient is. Actually, I just had a patient today that came in with exactly a 3-week-old posterior sternoclavicular joint dislocation. Very subtle on exam, but he had an obvious injury. So the diagnosis was that of a posterior sternoclavicular joint dislocation. We're going to get him in rehab. We're going to order CT to verify the diagnosis. But essentially, he wasn't complaining of much pain, did not have any obvious instability in exam. So this patient is going to get non-op treatment until proven otherwise. And as mentioned, closed reduction versus open reduction of these posterior sternoclavicular joint injuries can be performed. If there's persistent instability, then a ligament reconstruction can also be performed. There's some pretty slick techniques with minimal instrumentation that can be performed to allow for stability of the sternoclavicular joint in a safe manner. So final thoughts. As we've seen, these injuries can be catastrophic in sports, but they're relatively rare. I've been doing this, for 15 years now, and rarely have we had to send someone emergently to the emergency department for one of these injuries. And outcomes are definitely improved with having a good understanding and an action plan for treating various types of trauma. It's easier said than done, but obviously you want to remain calm. Do not be afraid to ask for assistance. Do not be afraid to disrobe the athlete where appropriate, and really dive in and get a good clinical exam that's going to lead to the appropriate treatment that's best and safest for the athlete to allow for the ideal long-term functional improvement. Thank you.
Thank you very much, Dr. Conduah, for that wonderful talk. So just as a reminder, please feel free to kind of submit your question through the chat function. While we kind of get ready for some questions, I do have a question for you.
Is my screen still on share?
Yes.
Okay, let me see if I can. Oh, there we go. Stop share. Okay, there we go.
So while we're waiting for folks to kind of write the question, the first question that I have for you is, in the case of an athlete with a traumatic knee dislocation with a multi-ligament injury, with maybe an ACL, PCL, as well as a meniscus injury, is that usually something that you fix all at the same time? Do you stage the surgery for those type of injuries? And how do you cancel the athlete or the parents in terms of returning to sports and returning to play?
Yeah, that's a great question. I think it's going to depend on the injury, going to depend on the timing. Depending on the number of ligaments that are disrupted, these injuries may be staged. So as far as setting the stage, I think the most important thing, as you mentioned, is counseling the patient, the athlete, and their family. You really want to lay the crepe, especially for these knee dislocations. More often than not, stiffness is the enemy, even post-surgery, and they may require additional procedures to manage their stiffness as far as maintaining and improving their range of motion. Depending on the injury, these surgeries can take several hours, so therefore that in and of itself might call for a staged procedure. So number one is getting the range of motion. If there's a significant lateral-sided injury that's able to be repaired, you can do the lateral-sided injury early to repair it, allow for range of motion, and always go back and do the combined ACL, PCL, and meniscus work, depending on the nature of the meniscus, as long as it's not a bucket handle tear. And with these knee dislocations, as I mentioned, it's a pretty devastating injury. Patients get really stiff. If they do return to play, as far as return to that same level, it's less than 20%. Willis McGahee is certainly an outlier in that he's able to return from a knee dislocation injury. So counseling, I think, is super important, managing expectations, and almost expecting the knee to get stiff as part of the counseling process is also of paramount importance.
Thank you for that answer. I guess my second question pertains to the next joint, the hip. How often do you find it that when you try to relocate the hip on the sideline, you get a successful relocation? Is there something that, it's recommended on the sideline, or depending on your comfort level, you just don't do it at all?
Yeah, I think it's certainly dependent on your comfort level, and the hip is a tricky joint. Hip dislocation can masquerade differently. A femur fracture can act like a hip dislocation in terms of the position of the limb. So I think importantly, it's early detection that the patient or athlete has a significant injury and getting them to the emergency department where you can actually perform the radiologic studies to really get that diagnosis. Reduction of the hip is pretty straightforward, especially for the posterior hip reductions, as long as the patient is well sedated. If there's an associated acetabular fracture, of course, that leads to instability of the joint, and the joint can actually sublux or redislocate, requiring fixation of the acetabular fracture itself. So the key is, early diagnosis, which leads to early reduction, which leads to minimizing the risk of subsequent avascular necrosis. After we reduce these hips, it's important to follow them with serial MRIs. At about 4 to 6 weeks, you get an MRI to look for the presence of any marrow changes. In the absence of such, the risk of the patient going on to develop avascular necrosis is much lower versus early marrow change findings.
You also made a comment about you could have vascular injury even if you feel the pulse. Can you please maybe elaborate on that or counsel us on some of the ways to make sure we don't get deceived when we see this type of injuries? What are some of the things to keep our eye on?
Yeah, I think in regards to these, especially for knee dislocations, I think in any setting of a knee dislocation, because of the higher incidence of associated, vascular injuries, you want to get vascular imaging. Typically, a CT angio or CT with IV contrast and a runoff is sufficient. Vascular injuries range from a stretch of the vessel to complete rupture to intimal tears, and it's the intimal tears that can occur at the lining of the vessel that can lead to a false sense of intactness as far as the vascular exam goes when you feel for the pulses. So it's certainly important to do imaging studies of the vasculature after a knee dislocation reduction.
So I got a question from the audience. The question reads, for sternoclavicular joint dislocations that are asymptomatic or over 3 weeks old, would you recommend you reduce that, or how would you manage that?
Yeah, I think that's the key. I think as surgeons and practitioners, we tend to want to treat the x-rays, treat the CT scans. It's important to treat the patient, not so much the imaging. So 3 weeks old, it's been quote unquote a while, and the patient is asymptomatic, meaning they're not complaining of much pain or limb dysfunction or even instability. So in those cases, I would let them be. They can scar in and do well and return to play in a matter of several weeks. Especially the anterior dislocations, which we see. Most of these sternoclavicular joint injuries that I see in my practice tend to be a week or two old because they oftentimes go undiagnosed. And by the time they present, they're a few weeks out, minimal pain, I actually had a very interesting case the other day of a young lady with Ehlers-Danlos syndrome, essentially ligamentous laxity, who came in with reporting, pain after she was stretching and instability of her sternoclavicular joint. Upon exam, I could actually sublux and reduce her sternoclavicular joint. And because of her diagnosis, I checked her other joints for laxity and actually checked her opposite sternoclavicular joint just to test it. And I was actually able to easily reduce it, sublux it, and reduce it back again without any pain. So in this specific setting, you want to take your time in terms of offering surgery to reduce that instability, especially if associated with Ehlers-Danlos syndrome, where the patient isn't very symptomatic. So we rehabbed her and she's doing well. She can still make her sternoclavicular joint sublux, but it's not painful and it doesn't affect her function.
The next question we have on the chat is, given the hemodynamic instability a femur fracture could have, will having a tourniquet on the sideline be useful?
Yeah, great question. It depends on, the location of the fracture, and it depends on where the tourniquet is placed. I think it's better than not having one, honestly. The only issue with having a tourniquet on the sideline with these types of injuries is you can actually increase the compartment pressures and inadvertently, lead to higher risk of compartment syndrome. So typically, tourniquets are not used in the setting of femur fractures.
If there's any more questions, we'll take it. Otherwise, I just want to thank each and every single one of you guys for joining today. Dr. Conduah, that was a great talk. I really appreciate your presence today, and hopefully look forward to seeing you guys next week on our next talk, which is the medical legal aspects of sports medicine. Thank you all and have a good evening.
All right, thank you. It's my pleasure.